Welcome all of you to the 43rd live webinar on orthopedic principles. This time we are back again with Dr. Balaji Purushothaman from Sunderland Royal Hospital, United Kingdom, to speak on pyogenic spondylodiscitis. Dr. Purushothaman is a spine surgeon in the United Kingdom and he has been trained extensively all over the world. He has done fellowship in Brisbane, Australia, and multiple fellowships across the globe. Over to you, Dr. Purushothaman.
Thank you, Hitesh. Thanks for the opportunity to come back to your webinars and talk about pyogenic spondylodiscitis. So we're going to just look at a case presentation. This is a very common topic for the fellowship exams. It comes in your vivas quite regularly. So this is a case of a 70-year-old man who presents with chest pain and also some back pain. He's also short of breath. He does not have any sputum on production. So he's actually admitted under the medical team. He's got a past medical history of COPD. He's also an ex-smoker. He's known rheumatoid arthritis on methotrexate. He was admitted under the medics 2 weeks previously with sort of similar symptoms, was diagnosed with community-acquired pneumonia, treated with antibiotics, got better, and was discharged. So this time he's been readmitted. His admission white cells were 11. His CRP is 167. They suspect whether he may have community-acquired pneumonia again, or whether he may have pulmonary embolism. They start him on antibiotics. They organized a chest X-ray, which showed blunting of the costophrenic angle and a shadowing around the base of the right lung. Because of complaining of some degree of back pain, they also get this X-ray of his thoracic spine. This shows possible narrowing of a disc space in the mid-thoracic spine. Just 1 second. Sorry, I'm just trying to get the pointer on. So you could see that, the narrowing of the disc space here. And they also get a CT chest because of this suspicion of pulmonary embolism. And on the CT chest, you can see there is some end plate changes, but this just gets reported as degenerative changes. This is the scan from 2 weeks ago that he had. And then at this current admission, he goes on to have a repeat MRI scan, CT scan. This showed that he had a subsegmental embolus and also possible discitis at T67 because of the progression of the end plate changes seen at T67 compared to the previous scan that was done 2 weeks ago. Now, because of this diagnosis, the medical team go and examine him again, and they find that he has normal neurological examination. And because he's already been started on antibiotics, he's been referred for an MRI scan to look at the destruction in the spine at further detail. He has an MRI scan, which shows the further destruction in the end plates and also in the it's sort of extending into the spinal canal. There is some degree of epidural abscess and spinal cord compression. While he is in hospital, this sort of gets worse. His back pain gets worse. He starts noticing that his legs are a little bit weak when he stands up. And every time he coughs or sneezes, he gets pins and needles down his legs. He's not able to stand up. Then he's been asked by the orthopedic team to be reviewed. When we see him on examination, as noted that he's not able to stand up now because of the pain. Lower limb examination, power is normal when you examine him bed. His reflexes are brisk and he has upgoing planters. So what do we do? So we're going to go into the topic of spondylodiscitis to know a bit more, and then we would come back to how we would manage this case. So these are the topics that we're going to cover today. We're going to look at the definition, the epidemiology, what are the causes of pyogenic spondylodiscitis and how this happens and how these patients present, how we diagnose them, and if there are any classification systems, and look at the treatment options and also the prognosis. So what is spondylodiscitis? It's the infectious disease of the intervertebral disc space and the adjacent bone, which is the vertebral bodies. 3 to 5% cases of all osteomyelitis are secondary spondylodiscitis. It usually has a bimodal distribution. It's present in children and also in older people, usually beyond 50 years of age. It is more common among men than women. The annual incidence has been reported to be around 2 per 100,000. However, there are more new studies now which show increasing trends. There is a study from Denmark which has shown nearly double the incidence than this, around 4 to 5 per 100,000, and a Japanese study quoting around 140% than what the annual incidence in the other parts of the world are. So there is an increasing incidence now. So why is this happening? So there are two reasons: one, patient factors, and also diagnostic factors. With regards to the patient factors, we know that there is an aging population, there is an increased life expectancy, and these patients who live longer have chronically debilitating and immunocompromised conditions. And also, we know that there are a lot of spinal interventions that are happening now, more spinal surgeries. As far as the diagnostic factors are concerned, people are more aware of this condition, and also we have much better investigations these days which have higher diagnostic efficacy. Because of these reasons, we've noticed increasing trends of spondylodiscitis. So what causes this? Mostly it's bacterial. Staph aureus contributes to more than 50% of spondylodiscitis. Other organisms like E. coli and Pseudomonas have also been attributed to. Pseudomonas is mostly common among intravenous drug abusers. Coagulase negative staphylococci, like Staph epidermidis, is commonly seen in postoperative discitis. Streptococci is seen in patients who have underlying endocarditis, in whom discitis has happened subsequently because of a hematogenous spread. Mycobacterial discitis is a separate topic on its own. Fungal causes include Candida, Aspergillus, and Cryptococcus, and other rare ones like coccoidoides and blastomyces have also been attributed to. In the Mediterranean countries, parasitic infections are quite common, and also is not to be forgotten about Brucella. Most of the time, the spondylodiscitis is because of only one organism. In less than 10% of the cases, it is polymicrobial. In these cases, it has usually happened because the infection has spread from surrounding areas, what we call as a contiguous spread. So remember, it's mostly monomicrobial. So how do these infections get here? The most common route is a hematogenous spread. A direct inoculation can happen like postoperatively, or when patients have undergone spinal injections, a lumbar puncture. Contiguous spread happens when they have an infection in the neighboring area, like from a lumbar, from around an abdominal infection can spread into your lumbar spine. ENT infections can spread into your cervical spine. So what happens when these bugs get here? These organisms are usually reaching the spine through the small arterioles in the vertebral bodies. They get deposited in the vertebral bodies. From there, they migrate into the disc, and the discs, because of the avascularity, some harbor these organisms, and they spread from there slowly into the end plates. Because of the avascularity of the discs, they do not get much of immunity getting into there to get rid of the infection. And also, when you have to treat them with antibiotics, you have to treat them on a longer term to get rid of the infection. So what happens once these microorganisms get in there? They cause bone destruction that can subsequently lead into segmental instability, which may also cause neurological deficit. Also, if they develop an epidural abscess, that can also produce a neurological deficit. How do these patients present? Most common feature is back pain. But because we know back pain is present even otherwise in quite a lot of people, it gets sort of neglected. And that is one of the reasons why the time to diagnosis is quite long. The other ways they can present in 1/3 of patients can present with neurological symptoms. Only very small proportion have systemic symptoms. As we talked about, this can also be present in children. Usually children have difficulty sitting or a pain while walking. They also, the infants have a refusal to crawl. Remember that there is usually quite a significant delay before these patients are diagnosed. So is there a difference with a clinical presentation with patients between pyogenic spondylitis and tubercular spondylitis? With pyogenic spondylitis, majority of the time patients will have fever, but in TB, it may or may not be present. And even if it is quite intermittent. Pyogenic spondylitis, as we mentioned earlier on, you have really young or pretty old patients, while TB spondylitis is in between the age. The duration to diagnosis is comparatively sooner with pyogenic compared to the TB because of the indolent nature of the disease. ESR and CRP are quite significantly high with pyogenic spondylitis compared to TB. So it's very important to know about the red flags. As we talked about earlier, the extremes of age is a red flag. Patients presenting with systemic symptoms like fever, night sweats, chills, rigors, any recent infection is very important to be noted, and also to see if they have any cause for being immunocompromised. Any previous or a recent history of surgery is also a significant risk factor. On clinical examination, you may notice deformity to their spine. This is more common with TB. You may notice tenderness in the midline or in the paravertebral muscles. They can present with muscle spasms. Thorough neurological examination is very important to elicit any subtle neurology developing with these patients. How do you diagnose them? So you could clinically doing laboratory investigations, radiological investigations, and also microbiology. You need to have a cohort of all of these investigations to help you make a diagnosis. So clinical diagnosis you can make with by eliciting a good history inclusive of these red flag symptoms. Lab tests, you should do a full blood count, inflammatory markers including CRP, ESR, and the more recently used one, a procalcitonin. Blood cultures should be sent. You should also do a baseline renal function test and liver function test. This will help you to know what their baseline is, and also as you're treating them with antibiotics, if there is going to be any change to their liver function, it will help you adjust their medications accordingly. So as far as the radiology investigations are concerned, the MRI is the most commonly used one, and you should always have a contrast enhanced MRI to help you with the diagnosis. Adjunct investigations like gallium bone scan or a gallium SPECT CT can be used. The more commonly used one is a FDG18 PET CT scan. The FDG18 PET CT scan has shown to be more sensitive and specific, especially in the early stages of the disease, like within the first 2 weeks. So when a patient presents with a short history and you're doing an MRI scan and it's not showing you any significant changes suggestive of discitis, if you do a FDG18 PET CT scan, it might show you, it is more helpful at that point. But after 2 or 3 weeks, an MRI or a PET CT are equally diagnostic. So how is the presentation different between pyogenic and TB on an MRI scan? So when you think about pyogenic spondylodiscitis, the disc is more significantly involved than in a TB. The bone destruction is comparatively milder in pyogenic compared to TB. The number of vertebral bodies involved is usually only 2 or 3 in a pyogenic, while it could be multiple, and it can also be at the skip sites. The vertebral body enhancement and contrast is quite homogeneous with the pyogenic, while it is heterogeneous and focal in cases of TB. A biopsy is very useful in making a diagnosis. Usually, if you have an organism positive on a blood culture, then you can use that to guide your treatment. However, if a blood culture is negative, then a biopsy will definitely help. As spinal surgeons, we prefer to do the biopsy because we can actually look where exactly the vertebral body is involved and use fluoroscopy to direct the biopsy to that spot and do the biopsy. What you need to remember is many of these patients are usually presenting late, and they might have already been treated by other medical personnel, like they might be under the general physicians who may have already started them on antibiotics. So if the patient has already been on antibiotics, you should see if it is safe to stop the antibiotics for a few days, at least 48 hours, so that you can increase your usefulness of the biopsy. However, if that is not possible, then you can still proceed with it. It is important to remember that around 1/3 of patients may have a negative biopsy. You can consider repeating the biopsy, and sometimes you might get a better yield around the second time. And studies have shown that second biopsies have been helpful in getting a diagnosis. This is a Harlow-Wood biopsy needle, which we commonly use. This is not that easily available these days. So how can we classify spondylodiscitis? You can have an etiological classification, have an anatomic classification, or a clinico-radiological classification. The etiological classification is based on what organisms, and this is something that we've been through previously. It's a bacterial, like Staph aureus, E. coli, Pseudomonas, coagulase negative staph, and also streptococci, mycobacterial, fungal, and parasitic. The other type of etiological classification would be a hematogenous spread, a direct inoculation, or a contiguous spread. An anatomic classification would be discitis, osteomyelitis, spondylodiscitis, and epidural abscess. Usually you get, it is a spectrum starting with discitis, spreading into the bone, and then having an infection in the disc and in the bone, combinedly calling as a spondylodiscitis. We do see cases when patients present with spontaneous epidural abscess without any involvement of the discs or the vertebral bodies. Paula et al. Have published a clinico-radiological classification system where they've divided it into A, B, and C. In type A, there is no bone destruction, there is no segmental instability, and no neurological deficit. In type B, there is bone destruction with or without instability. Type C, patients have epidural abscess with or without neurological deficit. So this is a demonstration of the three types here. You can see type A, where it is just only in the disc. There is no evidence of any cord compression, no nerve root compression, no neurological deficit, or any segmental instability. This is type B, where it is involving the disc and also the vertebral end plates. This is a type C, where you see there is no involvement of the bone or the discs. However, there is a significant epidural abscess in the thoracic region. And this patient had neurological compromise. So how do we treat these patients? The main aims of treatment is to eliminate the infection, reduce the pain, which may be because of the instability also, and also most important is to restore the spinal function, which is eliminating any instability and addressing any neurological deficit. How can we do this? Medical management and surgical management. As we mentioned at clinical presentation, only 1/3 of patients have neurological compromise. Majority of them are just having only back pain. So medical management is the mainstay for most of these patients. How do we treat them? Antibiotics. The most important thing is knowing the correct antibiotic, which is specific to the organisms that they have, which is usually directed by the blood cultures that they've had previously or from the biopsy. You treat them with intravenous antibiotics till their symptoms are settling, and also guided by what their inflammatory markers are. Usual thing is, once their inflammatory markers are coming down, then you can, and the patients are more stable, you can change them to oral antibiotics. We recommend treating them for at least 3 months total duration of antibiotics. A regular monitoring, when you start off with, you would do at least twice or thrice weekly blood tests to check their inflammatory markers are coming down, and also check their liver function tests and renal function tests. And once you know the disease is a bit more controlled, then you can reduce the frequency of blood investigations to be doing them twice a week, and then slowly reducing to once a week. And if they are quite stable, then you can do them fortnightly. But we definitely recommend antibiotics for a total period of 3 months at least. And once they've stopped their antibiotics, you should do their blood tests for at least further 2 weeks to ensure that there is no change in the inflammatory markers. So when do we need to operate on these patients? If patients have spinal instability, which is causing pain and also causing any neurological deficit. These are the main indications for surgery. So what sort of surgery do we do for these patients? If the patient presents only with an epidural abscess, then you can consider a decompression alone. But majority of the time, these patients may also have associated instability, and hence you may have to do a decompression and a fusion operation. How do you do this operation? What approach do you use? You could do it through a posterior approach, most commonly used in the thoracic and in the lumbar spine, an anterior approach for the cervical spine, or a combined anterior and posterior approach. You could do them through a completely open approach if the disease is quite extensive and significant destruction of the bones. Minimally invasive stabilizations can be done when the disease is in its early stages, causing instability alone, or a hybrid where you stabilize them and then do a local stabilize them doing a minimally invasive technique and do an open decompression at the level of the abscess. So this is a case, as I showed previously, has got an epidural abscess. This would be amenable just for a decompression alone because of the acute presentation, and then see how they would progress. If there is any instability happening over the period of time, then you may have to consider stabilization. But this lady, this is a 35-year-old lady who did very well with just a decompression of her epidural abscess. So going back to the case that we presented initially, a 70-year-old man presenting with chest pain and back pain as well. So you could see the destruction of the end plates, and on the MRI, you could see that he had an epidural abscess, which is pressing on the spinal cord, and his clinical examination findings in keeping with the spinal cord compression. So you would consider stabilizing him and doing a decompression. So this was a minimally invasive stabilization done 2 level above and 2 level below, and a localized decompression at that level. And he did well. At 6 months follow-up, he does not have any neurological deficit. He's mobile independently. So how do these patients do? A study published in European Spine Journal in 2018 by the same team who did the classification, they've noticed a few negative prognostic factors like negative microbiology cultures, or presenting with neurological impairment at the time of diagnosis, or if the patients have an underlying endocarditis, these were considered as negative prognostic factors. More than 90% of the patients healed with antibiotics and treatment, and they've got rid of their infection. Residual disability was noticed in around 23%, which is nearly a quarter of them. The mortality rate was around 7 to 8% in the cohort. This is pretty much the same with majority of the other studies that have been published. So it is important to remember that this is quite a serious condition with a mortality rate of around 10%, and there is some degree of residual disability, at least in a quarter of the population. To summarize, it is important to remember there is an increasing prevalence of the disease. Most commonly, it is a heterogeneous spread. Remember to elicit the red flags in the history. You should do a thorough neurological examination to identify any any fine deficits that might be present. These patients are usually managed by a multidisciplinary team approach. Antibiotics are the mainstay of treatment, and remember that they need to be treated for long term. And surgical options are reserved for patients with instability or neurological deficit. Thank you.
Thank you, Dr. Balaji, for that excellent presentation. There are a couple of questions that have come up.
Yeah.
One is, in general, not only for infections, do you use intraoperative vancomycin powder in your surgical wounds?
No, we don't routinely use them.
Okay. Do you think it has some benefit? A lot of papers for intraoperative use of vancomycin to reduce spinal infection.
Not for a routine use, because you can lead to drug resistance with that.
Okay. So does anyone across the UK use intra-op installation of vancomycin?
No, and as far as I'm aware, no. But when I was doing my fellowship in Australia, we did start using them for some time. But then we found that when we're using the vancomycin powder, that can sometimes cause serous discharge, and we may have some problems with it. So that is why.
So do you think in this particular scenario where you have infective spondylitis, you think adding vancomycin is going to have some benefit?
It depends on what the organism is.
What if you have not, I mean, you have a strong suspicion of infection and you have not organism and you have gone and you have explored the wound.
Yeah.
And you have sent the material for biopsy and culture. Do you think vanco has a role?
Yes, you can consider it, but it's not something that we routinely do that.
Okay.
So I don't know whether it's in the Asian countries, there is increased usage of vancomycin.
Yeah, there is a lot of, because I'm asking this question because a lot of papers of late, they have suggested use of vancomycin at closure.
Okay.
What you said, very important, is the emerging resistance to vancomycin and extreme resistance to other similar drugs. So to create a different group of superbugs by using this. So I just wanted to know what is the practice there.
Okay. No, now that you've asked again, like I do remember using it during my training times in children when they've had like, post-operative scoliosis, when they've had infection. We have used them a few times, but again, trying to use like how we would use an arthroplasty using the beads as well. But again, there's a varying trend to, what you do with them.
Okay. The other question is, have you encountered brucella? Brucella is...
Yes, it's not specifically here, but it's more commonly reported in the Mediterranean world. The brucellosis, you should remember, when patients from the Mediterranean countries, they're present with spondylodiscitis, that is something to be borne in mind.
Yeah, the reason I asked is when I was doing my internship in medicine many years ago, I had a patient who had a fever that was diagnosed as a pyrexia of unknown origin. You know that fever that is more than 21 days is generally labeled as PU, and you do all investigations. Interestingly, this patient had a unique combination of back pain, fever, splenomegaly.
Okay.
Tried, we looked at and we sent the material for microbiology and we could diagnose brucella. And then rifampicin is going to be a very important drug in such cases.
Yes, that is, it's a good point that you reminded that. So most of the time when we treat these patients with antibiotics, we get it's always a multidisciplinary team approach. We discuss with our microbiologist and mostly they get 2 drugs. Rifampicin is usually added on to help with bone penetration, and majority of the time, because it is Staph aureus, if they're going to be treated with flucloxacillin, then usually rifampicin is added in as well. It's usually a multi-drug treatment.
True, because even for infected joint arthroplasties as well, rifampicin is being found to be very useful for prosthetic joint infection, right?
Yeah.
Okay, so those, I think your lecture was very clear, and these were the only questions that have come up. Because it's like standard infection, right? It's you debride and...
Yeah, exactly. But the most important thing is the time these patients take to present and the complexity what they present with. That is what makes it more difficult. It's always remembering that, and that is the reason why we are seeing an increasing prevalence of these cases these days. Aging population, we have much better scans, easy availability of MRIs. But again, MRI sometimes in the early stages may not show an infection, and it just mimics like as if it's like a degenerative change and just gets reported only as a degenerative change. But if there is a suspicion, you should always get a contrast enhanced scan or a PET-CT scan, because a PET-CT scan is more sensitive and specific in the early stages of the disease to narrow down the diagnosis. A bone scan is also helpful, but the bone scan is only going to show the bone activity, which might be quite difficult sometimes to differentiate between a tumor and an infection. And again, a bone scan is not going to help you show what is happening to the soft tissues and around the, if there is an epidural abscess and things like that.
True, Balaji. Since you've discussed this, the other question that came to my mind is, how often do you encounter tuberculosis there?
Not very often, maybe 1 or 2 cases a year. But again, now because of the increasing Asian population here, we do see them, but again, it's not as common as pyogenic spondylodiscitis.
Okay, so before you really intervene in a case of pyogenic spondylitis,
Yeah.
would you like to do a test? For example, there are tests like Gene Expert or CB-NAT to rule out or pick tuberculosis.
It depends on the patient presentation, what ethnicity they are, and also what the MRI scan findings are. If we have already got a bug either in their blood culture or in their thing, then we don't really go into it. But if there is any suspicion that it might be TB, like the MRI scan findings or the ethnicity of the patient or any risk factors, yes, then, and if we are not narrowing down any bugs, then definitely that would be on our list to do those investigations.
Okay, Balaji, thank you so much. I think there are no more questions because this was a very crystal clear lecture, and you have clearly pointed out that a pyogenic spondylitis is something that can be easily missed, and picking up is one of the most important, the clinical acumen that you need to develop, right?
Yeah.
Okay, Balaji, thank you once again for being with us, and we look for, I'm sure you had a very busy week and you were, quite busy operating as well, isn't it?
No, that's fine.
Okay, thank you once again, Balaji.
Thanks, Hitesh. Thank you very much for providing the opportunity.